Okay, if you just give me the go, I'll start the recording and I'll take the roll call.
All right, good morning, everyone. Welcome to the ICD-10.
This conference will now be recorded.
There we go.
Good morning, everyone. Welcome to the ICD-10 committee meeting. Benton, I think you're going to start with calling roll, and then we'll begin.
Yes. I'll call the roll for the committee members. Dr. Soin.
Here.
Mr. Giacalone.
Here.
Dr. Johnson.
Here.
Dr. Reddy.
Here.
And Dr. Feibel. I believe Dr. Feibel has not joined us yet. We're also joined, I see, by committee board members, Dr. Bechtel and Dr. Schottenstein. Did I miss anyone as far as board members go? We do have a quorum for the meeting, so we're good to go.
Thank you. So I'll just get started. This ICD-10 Data Review Committee met 4 times in the calendar years of 2018 and 19, and you guys have some minutes that were attached in the agenda. At that time, we actually had some committee meetings with the Pharmacy Board, the ODH, Department of Medicaid, Ohio Department of Mental Health and Addiction Services, et cetera. And we created some agenda items, action items, and things like that. And the meetings haven't been really reconvened since October of 2019. And we all know, 2020, last year, we had a lot of other things going on that we had to manage. So some of the other agencies and some of us board members have expressed an interest in revitalizing that work of this committee, and that's what we're going to start doing today. So let's just kind of go over some of the major bullet points that we talked about at the last couple of meetings. So when the committee meeting met in the summer and fall of 2019, we came up with some action items, and I'm just going to go over some of those now. One of them was the website updated to add morphine equivalent dose per day supply tool. And it appears that this tool was made public in August or September, and there's a link in our in your agenda. The Medical Board e-news will include this link, as well as re-release and how to write a prescription and prescriber to pharmacy flow documents from the Board of Pharmacy. And the Medical Board was planning to write an e-news article with a link to the data tool. And this particular bullet point does not appear to have been done. The search tool was mentioned briefly in the magazine in late September 2019. Another agenda item we had was the Medical Board will reach out to prescribers in the 95th percentile to explore issues or challenges they are facing pending a Board of Pharmacy report. And the action there was we'd email prescribers who are non-compliant with strongly worded letters for the or those most non-compliant. The next agenda item was that staff from the Pharmacy Board and Medical Board will talk offline to discuss the desired data for date-based trends the Board of Pharmacy can share with the Medical Board. This did not occur. The next item was to identify the top 10 or 15 specialties and develop tailored communications, including average morphine equivalent dose and average day supply by conditions. And there's no evidence that we really have that we had tailored communications going out or specialties being identified. The next item was to begin discussions to develop consensus guidelines for managing back pain. There is no evidence this occurred. I'm sure Dr. Reddy will also let you know that there's a lot of guidelines and evidence and things out there that could easily be used and incorporated for this type of thing. The next agenda item is that Medical Board communications led to work on promotion to associations. In our agenda item, we were saying that there's no evidence that this occurred as well. But one thing I want to point out is when you look at how we're managing prescription drug abuse, I know that this agenda says there's not a lot of evidence that some of these things have occurred. There's a lot of things that happen in parallel, although they're not directly managed by this committee, right? So, for example, every physician that writes controlled substances gets this snapshot ORS report that's emailed to them, I believe, every quarter that lists their average morphine equivalent dose, the total number of pills read. It actually provides a graph that compares them to their peers, et cetera. And so although this committee may not have exactly done what the agenda items are listed, a lot of the information did trickle down to physicians in different ways, including identification if the physician was an outlier in terms of prescribing that came directly from the Board of Pharmacy. And so I think that's important to know. Perhaps we could duplicate some of that work out of this committee, but it's not that these things were actually not exactly being done. They were just being done through different means. So when we're talking about some proposed next steps, certainly things that we can talk about, and I'm sure some other people may have some opinions, but really to define the goal of the committee work and, what is the lens of what problem are we trying to solve? How can we best use this data to educate licensees about prescribing practices? And how can we capture and analyze specific ICD-10 data to show that something egregious had occurred or something that could potentially be harming the public actually, is occurring with those particular physicians or particular practice patterns? Also important to establish relationship with peers to become current on their work, right? And so all the other agencies I was referring to, because some of the other agencies are doing things, so good to collaborate. We could also identify policy gaps in what has not been done and what we could do better. Then finally, things like updating the website or working with the magazine to get information out there and determine how the data should be rendered for ease for use by the public. Determine how data could be rendered for ease of use by prescribers and even pharmacists, et cetera. And so that was just a basic overview on where we're at. Some things that we were hoping to do last year, and with all of the other struggles that we had last year, it might be time to review some of these. And that was my basic introduction. Stephanie, I don't know if you had anything in particular you wanted to mention in terms of other goals we have for this introductory meeting.
I don't actually. I think that brings it very well. I do just quickly want to introduce everybody, though, to Brandy Dorsey. Brandy is on the call now, and so from a staffing perspective, Brandy and Stuart Nealis will be helping us as we move through. Brandy has recently joined us from the Attorney General's Office of Medicaid Fraud and has a great deal of experience working with prescribers. And so we're happy to have her here. And so she'll be offering staff support as we go forward. But the issues are framed very well, and I think the committee, again, the real focus, I think probably today is where do we want to go next? What do we want to do with this next?
And in that regard, to frame that particular discussion, there's some pretty low-lying fruit of things that we can do immediately that would, really help us with some of our goals from last year. And what I'm referring to is just communication type stuff. Perhaps re-engaging with pharmacy board or whatever to talk offline about the data sets is something that should be pretty easy. Identifying outlier prescribers, messaging on our website or our e-news, like the how to write a prescription toolkit, et cetera. And then, data mining some of the guidelines that may already be out there or having those as resources for us to consider looking at. I mean, there's a lot of prescribing resources that have been done by various societies that are evidence-based and systematic reviews, et cetera, that have been done on opioid prescribing for different things, including back pain, et cetera, that might be starting points for us to do. I don't know if anyone else has any opinions on those, but we could, perhaps set some goals on doing some of those things. Like a re-release of how to write a prescription or prescribe it to pharmacy flow documents from the Board of Pharmacy, or we could write an e-news article with a link to the data tool on our next e-news that goes out. Yeah, Mr. Jackman.
Yeah, I think that's a good idea. The one thing about the pharmacy board, if I remember correctly, the data There's some questions surrounding some of the data too, because the way it was inputted by physicians, et cetera. We might want to get some clarity on that too before we decide to embrace it, because I think some of us had reservations. I think even the pharmacy board did, given that situation too. I think it's a good tool. I just would hope it's accurate.
Yeah, I mean, that's a good point. I see your hands up, Dr. Schottenstein, in terms of data accuracy. And I know that we had always talked about this from the very beginning, about concerns of this having, some sort of chilling effect, or, concern about how this data would be used. And, physicians may have been apprehensive about it. Although I will say, it's been going on for almost 2 years and we really haven't seen those issues. And so, but Dr. Schottenstein, I think you had your hand up.
Hi, thank you. So, I think this process has a lot of potential. I think that my own thought is that ideally it would be more of an educational process as opposed to a punitive one. Right now, we have no way, and you all can let me know if you disagree. I certainly have no way of, accessing a prescriber report on the ORS system and seeing how my prescribing, ranks against the prescribing of my colleagues. And so, it feels like that sort of bare minimum fairness for doctors to at least have that data so that they can assess for themselves how their prescribing habits fit in the context of their colleagues and self-correct if they feel the need to, as opposed to getting a letter, a strongly worded letter from the medical board, indicating that they are potentially in some kind of trouble when, they had essentially no way of knowing that their prescribing was out of the normal range of what they would tend to see in their colleagues. So I would be glad if we could have additional information that is made available to licensees so that they can assess for themselves where they're at. And I think that is really, the most meaningful kind of education that we could provide is for licensees to be able to see for themselves if they're, above that 95th percentile. And I'm guessing that for most of those licensees, it would get their attention in a meaningful way. And either they would feel like they could justify it, or they would understand on their own that they had overstepped and, course correct.
I see your hands up too, Dr. Reddy. I really appreciate that comment on so many levels, because I have no insight on what a lot of other people do other than people in my small community of pain physicians that, I communicate with often. And I can tell you this, it may be how things are set up in settings, or it may be, how I may pay a lot of attention to those things because I happen to write those, being a pain management practitioner. But, every quarter I get this email that comes into my inbox, and it's like a snapshot report, and it lists, like on the very top, it lists like the total number of prescriptions I wrote in the quarter, and it lists the average prescriptions that my peers wrote that are designated the same specialty, and then it lists my total doses, and it has graphs, and it benchmarks me against everyone else in my specialty. And I see that report that comes into my email all the time. But if you're not seeing those reports, you're right. We have to do a better job of making sure that those are pushed out to people. And I don't know if that's something that I proactively signed up for or did when I initially registered for ORS, but either way, that should be automatic somehow, that physicians can see it, because every time I get that, I really enjoy looking at that to understand how I compare to my peers. It is incredibly helpful. And I would think a lot of physicians that don't get that type of toolkit might benefit from that. That is an excellent idea, for us to ask the question on how are those reports generated? How do they go out? And what can we do to maximize that flow of information? And I think you have a follow-up, Dr. Schottenstein. I'll go to Dr. Reddy.
Oh, thanks very kindly. So I was just going to say, some time ago, with this thought in mind, I reached out to Steve, Shearholt at the pharmacy board, just sort of asking because, in the on the OR's website, there's a category, of prescriber report, and you can click on it. And whenever I would click on it, it would say this report's not available to you. And so I reached out to him, and he, was very kind to get back in touch with me and say, if I'm recalling correctly, because it was some time ago, that I think it's if you're prescribing opioids, maybe you get this information. But, a lot of doctors who don't prescribe opioids still prescribe things like benzodiazepines and stimulants and things like that. And I think it would, be helpful, of course, then to expand, expand the data to those licensees as well.
Yeah, that probably makes a lot of sense. If you don't prescribe opioids, it may not trigger one of those reports. Dr. Reddy, I believe you had your hand up.
You echoed my comments quite nicely. I'm a pain physician too, in addition to PMR. So I get this report definitely every year and quarterly, and it compares how I am doing with my peers and what's my dosage is. I think for controlled substances, the physicians who are writing do get this report, but I'm not certain if it goes to everybody. It comes from the pharmacy board, and it is quite helpful. The second thing I wanted to say is all over the Ohio and the prescriptions, how are we doing with these controlled substances as we have come into the prescription monitoring programs? Are we faring better, or are the prescriptions becoming less or more? I would be interested to know. In the state of Ohio, we know, as Dr. Soyen will confirm, all along the country, the number of controlled substances and particularly pain medicine use has diminished, and the prescriptions have gone down. So I would be interested in knowing how we are doing as a state as regards to the controlled substance prescriptions.
Yeah, and I can answer that partially for you. And one thing I can say is because there is a lot of data that the Board of Pharmacy has continues to monitor, and they occasionally put out reports, is in short, we've done excellent compared to where we were before, because we had a huge problem about 10 years ago. And the total number of pills has decreased substantially in the state. The total amount of morphine equivalent dose has decreased substantially. And we've seen decreases across those metrics. But interestingly, what we haven't actually seen a decrease on is the number of total overdose deaths per capita. And there's a lot of other factors associated with that. But to that extent, this board and the Board of Pharmacy, I think they've done a good job of decreasing the total number of pills used, which is excellent. And I can see if I can find some of those data sets for you, Dr. Reddy, actually, because they're kind of neat to see. And regarding next steps for us, I think that's a good point. Let me and us here sort of reflect and figure out what reporting is out there and what an efficient mechanism would be to let prescribers know how they compare to their peers and what the Board of Pharmacy has available. Like, do they only generate that report if it's an opioid? Those are great questions. So on that particular topic piece, I'll probably be talking about this at our next meeting with some updated information on that. We do have that link about the prescriber tool that's in our about prescription ICD-10 prescription data that's located in your agenda, and that might be something we can push out in an e-newsletter. And then maybe we could have at our next one or one following that maybe an e-news article with that link to the data tool as at least an immediate next step. And then after that, we'll also figure out better ways to get data to physicians. Dr. Fable, I do see your hand is up. Thank you.
Yeah, I'm sorry. I've been on. I just was driving back from surgery this morning, so I was listening, but not on my webcam. So I apologize, but I have been listening since the beginning of the meeting. And I have a couple comments. I echo Dr. Schottenstein's comments that I think the most important, I think one of the things the medical board gets a really bad rap among its licensees is that we want to do the right thing. We just don't know how sometimes, and it's not as clear as it could be. And so I don't know if I necessarily agree with that, but in that vein, this is a way we can help educate our licensees on what we believe is the right thing. And I think when those letters go out, and I think they're important to go out, and I think if we could do it by ICD-10 code, I think it's really helpful because people then can compare themselves apples to apples, and they don't just say, well, they're not comparing me to the right people. That way you have the right code, at least, assuming the data is correct. I think the licensees then can stack themselves up against it. And the letter that goes out should be non-punitive and very cordial to say, hey, we just want to educate you. And I think 99.9% of our licensees want to do the right thing. And those that want to do the right thing, I think it'll decrease their prescribing, and probably in a healthy way, because if they truly are in the 95th, 97th, 99th percentile and didn't realize it, they're going to think twice about it. Even if they thought they were prescribing correctly before, they're going to be more judicious about it. And I think that's what we want is people to be judicious about it. And so I think this can be a really helpful tool, and I think done in the right way can be a really positive thing for our board.
Yeah, I couldn't agree more. This is more of an educational tool, not necessarily a hammer, especially for the vast majority of licensees. Now, there will be occasional outliers that are just so far out there that they probably do need a heavier hand. And we learned this in the opioid crisis, that it literally would only take one practice or one physician in it to wreck an entire community if they're an outlier, just because the amount of prescriptions they can write day after day, week after week, month after month can really have a significant effect. And I think that's stuff we can see. But the approach that the Board of Pharmacy had when they sent that report to myself or to Dr. Reddy, for example, was interesting because it really wasn't even a letter. It was just like, here's your data compared to your peers. And then you just look at it and I guess you make your own conclusions, I suppose. And there's a lot of value to that too, assuming you're not a major outlier, right? I mean, that's the thing. So as far as next steps go, first of all, it's a great meeting, great to reconvene. I think we'll work on some sort of communication in the e-news as a first step. And then as a second step, I think we will really try to get a handle on what all of the messaging is given out to our licensees from the Board of Pharmacy or from ourselves, that benchmarking data. And Dr. Schottenstein, thank you for telling me that about the automated reports from ORS. I actually just assumed every single doctor got them. So I would love to connect with the Board of Pharmacy to understand that piece, especially if it's really easy for them to create those and send them out, even for benzos, right, or ADHD drugs or anything that has that potential. So yes, Mr. Check.
Sure.
Well, just to follow up on that, maybe we should reconvene another meeting with the pharmacy board to ask them these questions and also try to get a handle on the accuracy of some of this data to see if it's improved or we still have gaps. Before
Well, Stephanie, if that's something that's possible to arrange, I think that's a actually awesome idea. So we will do that.
Yeah, so I was thinking as a matter of next steps, so we as staff can connect with their staff and sort of do an inventory of what's going on, and then perhaps invite somebody from the pharmacy board to come to the next meeting, and we can continue that conversation on on what they're doing, or we can provide a report out. We'll see what makes sense, but I think it would be great to bring the groups back together to kind of continue. I think somebody mentioned this earlier. If something's already being done, we don't need to duplicate efforts, right? We're all on the same team. And so if they're doing something well, let's just market what they're doing well or expand what they're doing and not reinvent the wheel.
Excellent. I agree. Dr. Johnson and then Dr. Schottenstein.
Yes, so I would encourage us to also put out to the licensees that when they're having practice meetings, that they discuss this report that we're receiving. We've been doing that in my group, and it's been very helpful just to see what your partners are doing and how you can maybe lessen your opioid prescribing and seeing what they're doing so that you're consistently doing something within a practice. And that might be helpful information to share.
Yeah, great opportunity for the e-news, thing to have a sentence or two about that. Yeah. Dr. Schottenstein?
Thank you. So I recall, and from looking in the minutes, how it seemed like the larger chain pharmacies were being more compliant about inputting the diagnostic code. The smaller independent pharmacies were maybe not as compliant. So, that's something that maybe could be looked at by the pharmacy board. And also just looking at our website under resources and the conditions where it does list out those percentiles for MED, attention deficit disorder is one of the categories. And again, that would never happen, where somebody with a primary diagnosis of ADHD would get an opioid. And so it really speaks to the fact, I think, that sometimes these diagnoses are just auto-populated, and somebody might have ADHD in addition to a condition that is provoking, acute or chronic pain, and it just ends up going in the wrong bucket, so to speak. And so I think that ideally, attention needs to be paid to making sure that the correct diagnostic code is used, not just that a diagnostic code is attached to the prescription.
Oh, yeah. That auto population thing is probably an issue. I mean, a lot of the EMRs automatically pull the top ICD-10 code on there. And a lot of times those are just carried over from previous notes. You guys know how EMR work, and gosh, that could be a challenge. That's a good point. I think that's something we should talk about as well as we move forward. I don't have any other business other than what we described. I think we have our marching orders going forward. If anyone has any other comments, please let me know. Otherwise, we'll just proceed with what we talked about, working on the e-news, connecting with Board of Pharmacy, offline, taking inventory of resources, and then reporting back to you all of those things at the next meeting.
Thank you so much.
If there are no other comments, I'll take a motion to adjourn in a second. Yep, Dr. Feibel and Dr. Johnson. And all in favor say aye. Aye. We are adjourned. Thank you, everybody.
See y'all soon.
This conference is no longer being recorded.